stop sharing, I will just first share my screen, introduce you, and introduce my faculties with you.
Yeah, but it's not working. My presentation is not working.
Is it not working? Why?
I don't know. I will change, and I will use Japorama. It's terrible.
No, we are able to see your presentation. It's visible on the screen.
Yeah, I will choose full screen, and you will tell me if it's working.
Yeah,
it's working like this. It's working like this.
It's perfect.
Okay. I stay like this, okay?
Yeah, that's fine. So please stop sharing. I will share my screen first.
Okay.
Okay. Let me share my screen. You have to stop sharing. You please stop sharing.
You want to see video?
No, okay. I think it will play. Absolutely not an issue at all.
Okay.
Yeah. You please stop sharing. So that let me first share my screen. Then I will invite you to share your screen.
Okay.
Yeah. Have you stopped sharing? You haven't stopped it.
I stopped, yes. You wish I stop sharing. Okay.
Yeah, please click the stop sharing.
Okay.
Yeah. That's great. Yeah.
Okay.
So let me share first. Is my screen shared?
Yes, I see.
Oh, great. Okay, that's great. So good afternoon, everybody, all my faculties and residents in the department. So today in the first international guest lecture series, we have Prof.Joel Leroy. He is a founder and chairman of Hanoi High Tech and Digestive Center in St. Paul Hospital in Hanoi in Vietnam. Professor Leroy is a French. He is right now in France at his home. So Professor Leroy is a world authority on laparoscopic colorectal surgery. He is an educator. He is an inventor, and he is a surgeon par excellence, who in fact has given many new concepts in colorectal surgery. And he's a leader and pioneer in advanced laparoscopic colorectal surgery since early 90s. He is recognized worldwide as a surgical expert and educator, inventor. He has developed many standardized laparoscopic colorectal procedures. He completed his MD at the University of France in '76 and became the professor of digestive surgery in Lille Medical University in France. And then he became a professor of university in Winnipeg in Canada in 2003. Is visiting professor to Osaka Medical College in Japan, IRCAD in Taiwan, in China also he is a visiting faculty. But the most notable achievement he had was in 2013 when he received his Pioneer Award in Minimal Invasive Surgery in the American Surgical Society of Gastroenterology of Endoscopy SEGES conference in Baltimore. And he is the only non-American who has received this prestigious award. And most recently, he has focused his interest in the development of a new surgical center in Hanoi in Vietnam, the Hanoi High Tech and Digestive Center in St. Paul Hospital in Vietnam, of which he is the director, he is the brainchild, he is developing that digestive center in Vietnam, and he is contributing in many ways in the development of the surgical science in colorectal surgery. So in fact, my association with Professor Leroy was in same 2013, where he was awarded this Pioneer Award in Minimal Invasive Surgery, when I was presenting in SEGES, and after the presentation, Professor Leroy was in the front row, and then from there on we became friends and we haven't looked back. So that was 2013 and it's still continuing. That was the time when Professor Leroy was awarded the Pioneer Minimal Invasive Colorectal Surgeon, the prestigious SEJES Award in Baltimore. And that was in Hanoi after he has taken over as the director of this Hanoi High Tech Medical Center. So thank you very much, Professor Leroy, for accepting my request to join the department and address to our residents. And you always will be an inspiration. You will surely be a motivator as well for our residents, who all are fantastic, brilliant guys and girls who need just some kind of a motivation to go ahead in their life and in their career. So before you start presenting, I have the pleasure of introducing my faculties over here in the department. And we have Professor Santanu Kumar Sahu. Could all the faculties be visible? Yeah, so we have Professor Santanu. Sir is probably hasn't joined. Professor Santanu is a professor of surgery in the department. Another professor is there. Probably he is busy in some other surgery or in his OPD maybe. We have Dr. Prakash Kumar Sasmal that I introduced him in the beginning. He is an additional professor in the department. We have Dr. Mithilesh Kumar Sinha. He is an additional professor in the department. Dr. Manwar Ali, he is an additional professor in the department. And Dr. Pankaj Kumar, he is an associate professor in the department. Dr. Pradeep Kumar Singh, yeah, is an assistant professor in the department. Dr. Bikram Raut is another assistant professor in the department. We have got around 12 surgical residents, 8 senior residents. We usually run a postdoctoral fellowship course in minimal access surgery. This is the only center in the eastern zone of the country which is running this course. But this time we do not have, our candidates have passed out, the new ones, they haven't joined. So it's a pleasure to have you, Professor Leroy, amongst us. And before you start, I must wish a belated happy birthday that you had yesterday. So I came to know that you celebrated it in a grand way. That's great to know that. So let all the screen and air belongs to you now. So please start your presentation.
Sorry. You have the sound now?
Yeah. We have the sound and
thanks, Manash. It's a great honor to be with you and to see all the team around you, a young team and very active. And it's always great pleasure for me to share my experience and my idea concerning minimally invasive surgery. I began 30 years ago, beginning of the 90s. And I'm more focused on colorectal, but I did a lot of other procedure. But since a long time now, more than 20 years, I'm focused on colorectal. So I will share the presentation. We have discussed and I have proposed to speak of bowel anastomosis, focus on colon, rectum, colorectal, and ready to share.
The other professor has joined, Professor Tushar Subhadarsan Misra. He is with a mask. He's the only one with who is protected against COVID. Could Tushar say hi and hello to Professor Leroy?
Okay.
Professor Leroy, this is Dr. Tushar. It's a pleasure having you here. We are all ears to listen to your talk over the next 1 hour.
Thank you. Yes, you can share your screen.
Continue, sir.
I think you are already sharing.
Yes, but it is your presentation online. So you have to stop your presentation, no?
Oh, yeah, great. I need to first stop it. Yes, I have stopped it.
Okay.
Now you can. Yeah.
Yes, I see. Okay, I will. So you have my. I choose share, and now I'm. Okay?
Yeah, it's coming up. It's coming up.
Okay.
Yes, great.
So,
It's already on. Yes.
we speak of bowel anastomosis, speaking of Iliocolic anastomosis, colocolic, colorectal, coloanal anastomosis. Seeing the basic aspect, the different techniques, and what choosing when we do some specific anastomosis, particularly for coloanal anastomosis. So the educational objective is to discuss the basic aspects, to describe the possible types of anastomotic techniques according to the type of bowel resection, and to discuss anastomotic specific function and surgical outcomes. Performing anastomosis between two segments of bowel is often challenging. Colorectal or coloanal anastomosis are particularly technically a challenge. And we will see the basic aspect. And I love to come back to basics because we see a lot of sophisticated publication concerning different tools. I'm thinking robot, but it is mainly surgical technique, surgeries that is the most important. Why I propose to discuss of that? Because our purpose is to improve the quality of colorectal anastomosis, reducing the postoperative morbidity concerning the risk of fistula, of abscess, of stenosis, and increase finally the quality of life, keeping good digestive function. First, and it is important to discuss, I don't know what you do in India. In Europe, it is not recommended to do bowel preparation, particularly in France, except for the rectal resection. And when we see the literature, the different type of bowel preparation were described. But there is a comeback to classical bowel preparation. In Asia, and particularly also in Vietnam, we do systematically bowel preparation with a mechanical bowel preparation per oral bowel preparation. And I have published recently in Anal Laparoscopic Endoscopic Surgery, it's a Chinese journal, concerning a review of the literature concerning bowel preparation with oral antibiotic for elective colorectal surgery, coming back to the future. And we have found that morbidity and the quality of surgical procedure are better when we do a mechanical bowel preparation, using also oral antibiotic before the surgical procedure. And it is what it is also recommended in states. In 90% of cases, the colorectal surgeon in the states are using. Why? To reduce fistula risk. And we know that there is multiple factors. Perioperative failure, bad vascularity, denutrition of the patient, and also other pathology as diabetes, arteriosclerosis. Respecting bowel vascularity, how we do. It is important to know that it's not because we do minimally invasive surgery that it's a minimally invasive or aggressive step for preserving the vascularity. So open or laparoscopy or other minimally invasive surgery, we have the same principles. Preserving the vascular network. Sometimes you have particularity of vascular network. For example, in this case, this is a real long arch, and you have to know if you respect it, you will have the possibility to keep a longer segment of bowel that will facilitate the anastomosis. If you divide it, you will have the problem of large ischemia. If you keep it, you can reduce the length of resection. And this is, for example, in this case, when we do a resection of rectal and sigmoid, the possibility to keep this type of anastomosis. We resect. And it is what I will do in this case. You see on the screen, I suppose you have the video?
Yes, yes.
Yes, you see the video?
Yes,
so, you see, you will see better and better. We have a beautiful, we have divide the HME. We have divide the HMV, and we see clip on the HMV. At this level, this is a clip on the HMV. We are separating the HMV from what we are thinking the left colic, but you see it's always beating. And it is these vessels like this, and I will keep this vascular network. And we will see the interest for the end of the procedure because we will keep a longer segment, particularly of the descending colon, with a good vascularization for the descending colon. This is what we are doing now. So we will remove, in this case, the sigmoid and vessel. We see this large anastomosis, and with a long vascular, you see the vessels beating. So it is important to understand this is the quality of the vascularization we keep. We see the vessels beating, and we will see how we can evaluate later. So we have to preserve. So the question is how to divide the bowel. And said it is for the younger, the resident. You see, when we divide the bowel and the meso, we can divide doing a cylindrical division, like this, at same level on the bowel and meso. This is good. With this, we have a division on the bowel and meso different, but we keep the vascularization on all the segment of bowel. Same if we have an obliquous division, longer on the meso, shorter on the bowel, and shorter on the antimesenteric side. This is how we can say what are the best manner to do. Probably the second one is good, but the third one too. Cylindrical division is important of the bowel and the meso. You see some possibility of division. If you do a division of the meso like this and the bowel like this, you will have a risk of ischemia at this level and fistula if you do the anastomosis at this level. Same if you have larger bowel resection than the meso, or larger resection of the meso, you will have ischemia at this level. And same if you are obliquous like this, risk of ischemia. And this is what we can see during the preparation of the bowel when we do hand-to-hand anastomosis particularly. This is not good. Assessing, evaluating bowel vascularity, how we can do. First, I recommend to do early division of the marginal vessels. Because if we do the division, where we will do the anastomosis and we do the division of the meso first, we will evaluate the ischemia after a long time. We say even with ICG, we will speak later, we have evaluation that is better after a long time. Watch this. We see first distally venous dilatation. Why? Because we have divided the vein, but not at this moment the artery. So there is a congestion and no possibility to backflow for the venous. And we see the color changing. You see, but it's after 2 minutes when we have divided distally. And after 10 minutes, it's changing and we see the difference of color. With a good camera, 4K video camera, we see the vessels beating there. You see, and we see the color changing. And after 20 minutes, it will be completely dark. It's why we have not to divide and to do the anastomosis immediately. Divide and continue your procedure later. And we can evaluate outside for sigmoid, for rectal resection, when we pull the specimen, and we can evaluate because outside vision, it's better. It's not only ICG that it is important. It's to see the color outside. This is a huge advantage for sigmoid because we will pull the colon through the orifice where we do the preparation of the bowel. This is a division of the meso. You see, till now, no problem. But we see the color, we divide. We have chosen to do the division approximatively at this level. And you remember I was saying to do the division of the meso more distal than the colon to keep a good vascular network. So we can divide like this and come back close. You see progressively the dilatation of the venous, of the veins, venous network dilatation. This proves there is a risk of late ischemia if we don't consider this. This is a big difference. You don't see perhaps, but with a 4K video camera, we have an interesting vision of what is coming. And after 10 minutes, 20 minutes, it will be very dark. You see, this is a good venous drainage. No venous drainage, because this is... So when we divide the colorectal junction, in this case, you have always a picture, because I have a bug coming, and you see the color is changing. We have divide distal. This is a big difference. Watch after 10 minutes, 20 minutes. It is when we will see the venous dilatation. And we see the limit, but we will divide higher. nobody is speaking of this. People are speaking of, I prefer to watch and to see vessels beating and to see no venous dilatation, because this proves that there is high pressure in the venous drainage. And it's dark. And more you wait, more you will see a difference of color. You see vessels beating. It is a more proximal you are, more you will see vessels beating. You will tell me, but it's not always easy. And you see, particularly in obese patients. And we have some technique to avoid, for example, in obese patients with very thick subcutaneous fat tissue, to do a complete extraction, because when we do extraction through a small incision, we will have a traction, a squeezing of the meso, with a risk of breaking the vessels and postoperative ischemia. So how I do? I limit the mobilization, because more you mobilize, more it is difficult. And more risk of injury, particularly of the meso and vessels. And this is an obese patient with fat meso. We do the extraction, but we will not do a complete extraction. You see, it's ischemic at this moment, at this level. But if I do complete extraction outside this part, so what I do, I pull, and I will introduce the anvil inside. I push, and I will now do the preparation outside. More fat is the patient, more we have to do like this. We introduce, we staple inside. This limits the mobilization, and we have the anvil, we have the sutures, we have different technique. We can do like this with the suture. We have seen the suture, we pull, and we complete in 2 times. We can do in 1 step, and we close the incision. And we try to do the anastomosis not on the mesenteric side, but on the anti-mesenteric side of the bowel. This is a technique I propose to limit the risk in obese patients during the extraction, the risk of breaking the meso. Other factor important, avoiding a tension on the anastomosis. Why? Because when there is a high tension on the anastomosis, there is a tension on the vessels, particularly the veins, and outflow will be less, with a risk of thrombosis postoperatively, particularly when there is postoperative edema in the pelvis. So it is why we recommend to do mobilization large enough to do a tension-free anastomosis, and particularly for the splenic flexure, when we do colorectal anastomosis or colo-low-rectal anastomosis, and particularly in obese patients, we have to do this, and it is necessary, except in Asia, where a lot of patients have a long sigmoid loop, and they are more slim than in probably India, but Europe, and mainly in States. Tension-free anastomosis. Oh, sorry, it is what we have to do. This. So how we do? We have to do. You have different possibilities. Mobilizing by lateral approach, like this, down to up. This is the lateral freeing of the colon. that is enough in 80% of cases in Asia. It's not necessary doing too much. We have to free the posterior attachment of the descending mesocolon and the transverse mesocolon and splenic flexure till we reach the pancreas, pancreatic tail, and we free the anterior attachment to the pancreas, attachment of the root of the transverse mesocolon. We see there the pancreas. This is the pancreas. This is the venous drainage, and we have the root of the transverse mesocolon at this level, and we will open the lesser sac at this moment. I had the... Sorry. So when we have finished to detach, we will take down the splenic flexure. Largely, we have to free the lateral attachment to the omentum or to free the omentum from the stomach. And you see the possibility to take down the splenic flexure to win length for doing the anastomosis without tension on the site of the anastomosis. For that, it's better to have a good camera. I have known at the beginning the camera, and with a good camera, and particularly for the ultra high definition camera we have now, it is, as you see, better because we can evaluate with spectrum close to the sun light, and we see the difference of color. We see that it is more and more visible, 10 minutes, 20 minutes, and you see purple, pink, and we see the limit. And we will not do the procedure at this level, but a division at this level. And it is what I recommend, respecting the basic principle of division, as I have explained at the beginning. Doing external examination, we see that this is an interesting aspect of the vision, human vision, with good light outside. And we see really the difference. And after we will have open, we will see also the margin of the resection that are bleeding, and with not with black blood, but red blood. Using ICG, finally, to see what? To see the same. We see on left, this is well vascularized, on right, not. But for me, there is no difference when we have a good camera. And ICG, it's also very expensive. But can be interesting when we do transanal surgical procedures. This is a procedure I do, as you see, when I do transanal surgical procedure. Why? Because it's more difficult and quality of scope is not so good. This is before doing coloanal anastomosis, colorectal anastomosis, we can use ICG, and we see very well at this moment the quality of the vascularization concerning the segment of Bowel. I will do the anastomosis. This is the colon, And also the rectal stump, the vascularization, this is intra-abdominal through transanal way. And we will evaluate too the quality of the vascularization of the rectal stump. You see now, it is a rectal stump we have seen before doing the anastomosis. But ICG, there is a limit. As I said, it is the same than when we do, I will say, visual evaluation with a good camera. If we have a good section, ICG, if we do the division after evaluating ICG vascularization, if we do like this, it will be good, good, good. But if, for example, we have a division and bleeding, no venous dilatation visible, this is a venous bleeding. You will not see hypertension inside the venous drainage. If you have division of the artery, you will not have this. And you see, in this case, it seems be good, but it's not good. So avoid this. Clinical evaluation of ICG. In experience of Luigi Boni, it's always to say it's good to do new evaluation, as always, but I have not seen, in my opinion, in my experience, risk of ischemia when I do as I have proposed to you. So they propose to do larger studies to evaluate. Why? Because you see, when the risk of fistula due to ischemia is around 1%, 2%, as we have in Asia, it's necessary to do thousands of cases to be sure that ICG is a good advantage. What kind of anastomosis we can do? End-to-hand, side-to-hand. I'm more pushing for colorectal, low colorectal anastomosis or coloanal anastomosis to do side-to-hand. End-to-hand, you can do mechanical or manual. You can use coloplasty. I tell you now, don't do coloplasty because Eric Rullier did a lot. It's a French surgeon doing a lot of colorectal procedures, and he had too many morbidity when he was doing this type of procedures with a lot of fistula. Doing colorectal or coloanal with a colonic J pouch like this, or without colonic J pouch. This is what I choose in the majority of cases. Doing end-to-hand, it is what we do when we do colorectal anastomosis at eye level, like this. And it is the technique using a stapler. And when we put a stapler, you see we have to not to put it the middle, we will see later, but more avoiding two ears on at the level of the anastomosis on the rectal stump, but having tennis racket shape to perform the anastomosis. And it is how we do. You see the stapling line. This is a circular stapler inside, and we transfix at the level of the stapling line, or little anterior, posterior, but we have to remove this corner avoiding 2 ears for doing the anastomosis, avoiding ischemic zone at the level of the ears. You see a small tension. That's why we will complete the mobilization. This is not good. We have to verify that there is no twist, because this is the case here. Technical aspect, you see there is a twist of the bowel. It's why we have tension too. So we have to correct the twist, always verified that there is no twist. You see the why? No problem, perhaps perioperatively, but later you will have a risk of venous thrombosis with ischemia, late ischemia, and you will have the thrombosis and late ischemia. And we see at this moment the possibility. So always control the anastomosis. As I said, I do side-to-hand anastomosis, same. I try to do always on the left side of the stapling line. And it is how I do, like this. I introduce outside, you see the anvil through a small incision. We have to keep minimum 2 centimeters between the anvil and the other stapling line. If it is less, you will have a risk of ischemia. And it is on the anti-mesenteric side advantage. We will not have, you see, I'm changing the position of the stapler because I don't wish to have 2 ears. I wish to remove the segment to have only, so we will do the anastomosis at this level as like this. This is important to do that, in my opinion. Why on this side, not on the other? It's because if I have to complete with a suture, it would be easier to do on the right side because I'm staying on the right side of the patient. You see, this is advantage. We divide the meso and the colon same time. We don't do a dissection of the mesenteric side of the meso. You remember, if we do, we will have a risk of ischemia. So doing side to hand, and it is what John Nichols were recommended even for colorectal anastomosis, I11, and it's easier to do this type of anastomosis. Only to remember, the rectum, we can transfix at this level 2 ears. And if we have a very small one, risk of ischemia, because you will have a risk of ischemia. Other possibility, what I recommend, it is this. And you see, this is very dangerous. If you have a large, 2 big ears, it's dangerous like this, like this, like this, and you see risk of ischemia at this level. So my choice, what I recommend, it is number 2. Side to hand anastomosis, doing coloanal anastomosis, like this. This is for coloanal. We have seen for colorectal. Coloanal, we have done transanal extraction of the specimen, and we pull the colon and we do side to hand. Same would be easier to do like this, and we can continue the anastomosis. But we have different possibility. We can do anastomosis with a reservoir, a J pouch. If it is colon, it's a small reservoir, 6-7 centimeter maximum. And we can do low colorectal anastomosis. As you see on this picture, it was proposed by two French surgeons, same time, Roland Park and Lazorte from Toulouse. You can also perform end-to-end. If you do that, it's better to have a good compliant colon. Having not using colon with a lot of diverticulum, because there is a risk of spastic colon, not a good compliance. You can do coloplasty, but as I said, I don't recommend because high morbidity. When we do transanal TME, we can do coloanal anastomosis, as you just seen. There is no difference, except we use different device for doing. We can do end-to-hand, side-to-hand, mechanical, manual, all are possible. Difficult case, always do a control. I do air test. First, you have to control the donuts, we will see, to control the resection when you do anastomosis with a stapler, circular stapler. Air test, what it is, we push saline serum in the pelvis, we clamp above, and we do the don't work. Sorry, where is my okay. I was looking after my arrow. We clamp like this, and we push air inside with a big syringe, and we are looking after bubble. If there is no bubble, it's not necessary to see the anastomotic zone. If you have bubble, we will see what to do. When we have, as in this case, bubble, we watch and we see this. And we have to see that there is a big evaluation. You see, this is the shape of staples, not close. So you have always to control your anastomosis. There is no leak, no bubble, but at this moment, in this case, what I did the sutures, I lift and did a new resection. So this is a lifting. I complete the preparation. Fortunately, it was enough high, having the possibility to do a new resection. So you have to prepare. So I did a suture, not to close, but to do a new resection for lifting, using the suture for traction. And always control your anastomosis to verify the shape of your staples. This is good technique. So we will transfix, you see, we will transfix at this level, and we will remove the crossing part. So this is a new anastomosis after new resection. This is a particular interesting case. We do the control. We can do with, we add bubble. We do with betadine solution. And we found a big fistula. Why? You see, this is a stapling line. And we have not included the corner of the bowel on the suture line. It is why. So what we did, a new resection, and we will do a new anastomosis. You see, this is a distal rectal resection. The shape of the staples are not good. This is not close. And we do anal examination. It was too low to do air test. And we see that when we push the finger in the small rectal stump, we open. So what we decide, it's too low to do a new resection. We decide to do side to hand anastomosis on a J pouch and doing coloanal anastomosis because it's too low, too close from the sphincter for doing a new resection. So we do handmade anastomosis. As you see in this case, we will do on a small reservoir. So this is what we are doing now. What is not good, it's to do multi-fire anastomosis. We have to do air test, betadine test. It is positive in this case, as you see. So we have used too many cartridge. We think it's good. We do air test, bubble. We decide to do betadine test to localize the hole. It's a small hole. It's a weakness. And as you see, I will have the possibility to do a new dissection to propose a new resection and anastomosis. Other possibility for doing colorectal anastomosis is to use a specific way, transanal, transvaginal, and I have published and I have done a lot. We can do using a transvaginal approach, as you see in those pictures. We clean this. This is where we have endometriotic nodule because I use this for endometriosis. We open this, we pull, we introduce the anvil, we push, we divide, as you have seen when I do in obese patient, and we close this and we do the anastomosis using side to hand. Other type of anastomosis, iliocolic anastomosis, isoperistatic, you can do an isoperistatic too, inside. This is after right colectomy. We have the small bowel there, we have the colon, transverse colon, we are fixed together, and we do two small holes. We can do handmade anastomosis. In this case, we do a running suture like this. We do incision. And I believe it's more important to have a bowel preparation in this case because we open the bowel with the risk of contamination. And particularly when we use stapler, I have seen so bad anastomosis with a lot of contamination of the stapler, that this is more bile in this case after bowel preparation. So we do the side-to-side anastomosis and we close the suture. The weakness is this: we have to close perfectly and to see the two corners of the anastomosis. I prefer to use monofilament. It is sliding better and easier. You can do with one running suture or two running sutures, distal and proximal, and with ligation at the middle. This is outside Iliocolic anastomosis. Even if we do outside, we do the preparation inside. So we fix together the two segments of bowel. And as you see, we do a fixation with sutures. We can do anastomosis inside, but it's only to show the difference. This is cheaper, particularly in emergent country. It's not necessary to use a stapler. We can do all handmade. So we have a forceps on the sutures, and we don't do outside really, but through the small incision. So you have inside, outside, and through the small incision, avoiding a complete extraction of the bowel that will be possible after a large mobilization of the transverse colon. We control if there is no bleeding, and we finish the sutures, manual sutures, closing the orifice where we have introduced the stapler. So this is, we can do complete handmade sutures. That is easy because it's really close. This is another type of anastomosis, Iliocolic Isoperistatic anastomosis. This is the transverse colon after splenic flexure resection. This is a sigmoid. We push the two segments together like this. And we will do, as you see, side-to-side anastomosis. We fix together the two stumps, and we introduce the stapler like this. We do use a 6 centimeter stapler. It's better. We have seen a 4 centimeter, but with the incision, we will have 6, 7, 8 centimeter long side-to-side isoperistatic anastomosis. So this is how we do. The question will be what to do with mesenteric gap at the end, because the mesenteric gap is a risk of bowel obstruction, internal hernia. I have described this with my fellow Sereno and Meran Handvari, that is also a Canadian surgeon that published my experience of 500 colectomy and with a risk of internal hernia, particularly for left colon. And after large colectomy, when we have a big mesenteric gap, there is a risk of internal hernia and bowel obstruction. We can also do outside, but it's easier. We can do isoperistatic easier to do an isoperistatic anastomosis like this. So we pull the two segments of Bowel. This is two columns. They have sigmoid and transverse. And we do side to side anisoperistaltic. That finally will be hand to hand at the end. In conclusion, anastomosis are often difficult, particularly in colorectal, and also when we want to do inside anastomosis for others, particularly Iliocolic anastomosis. The essence and functional results will depend on age, quality of the sphincter, status of the patient, surgical experience, local complication. If you have postoperative complication, and particularly fistula and abscess, the functional results will not be so good. And if you have, particularly in the pelvis, previous surgery, and radiotherapy. And the choice of the technique will depend on multiple factors: obesity, pelvis, tumor localization, failure, bowel compliance, and radiotherapy, irradiation. Thank you for your attention. I'm ready to answer to your question.
Thank you, Professor Joel, for a wonderful practical tips-oriented discussion. You have given everything step by step. I think most of the things you have made very clear. You have given the practical insight to the topic. I think our residents must have taken good tips from you. I will appreciate if our residents have any questions for you.
It's mainly focus for them. Back to basic.
Yeah, back to basics. Good. I think before they come, I think let us just initiate the discussion. That one point you told that ICG is an overkill for you. If you have a very good camera, ICG in fact doesn't make much of a difference for a colocolic or a colorectal anastomosis. Am I right?
Yes, good camera first, and respecting the basic step, as
Absolutely.
we were doing in open.
So
dividing very early the meso to evaluate, because during this time we will continue the procedure, and when we come back, we will see better the color of the bowel. And with the time, when I do the division of the meso, normally I do distal division, so no flow coming back. And I do the proximal division, where I evaluate the possibility to do the anastomosis. And I have not mobilized my splenic flexure. I will do the mobilization after, not at the beginning of the procedure. So I'm not ready for doing the anastomosis. It will take more than half an hour for doing the mobilization, complete mobilization. And when I come back, I see the difference of color. And it is how I have seen that. And I remember my friend, Frédéric Bretagnol, said to me, he's always beginning now by the division of the meso. Division of the HME, division, and after division of the meso, to evaluate better the color of the bowel. Remember, if you use ICG, it's a specific equipment, it's expensive. Now it's coming with 4K. If you have a 4K camera, it's better. You can see really very well the color. Okay. And for sigmoid, I'm sorry, but we can evaluate outside, because we see the color outside.
So do you not routinely mobilize the splenic flexor in all your low anterior resection or ultra low anterior resection?
Low anterior resection, I will say in 99% of cases. Yes. In low anterior resection, it is mobilized, yes.
Yeah, yeah. And regarding your mechanical bowel preparation with oral antibiotics, you told that European colon is surely
Yes,
different.
it's a washout with the day before the procedure, and as for doing a colonoscopy and antibiotic during the day before the procedures.
Okay.
It is, you can read, I can send to you the reference of the paper because we analyze the literature, and this is really what is coming back actually.
Right,
And
right.
believe me, when we operate a patient with a flat bowel, it's so easy, so nice.
Absolutely, absolutely. We also routinely follow that protocol. We always prepare our bowels. So we do not do any unprepared bowel, in fact. And what about you told that always you prefer a side to end anastomosis? That's in fact is much better than the conventional end to end anastomosis.
For me, concerning the vascularization, it's better.
Yeah.
It's not my opinion. It was in open the case for St. Mark's Hospital in London. I was invited to operate. I remember I was doing a sigmoidectomy for sigmoiditis. And John Nichols were sharing the session. And he's a good friend of mine. And he was saying, when I was ready for doing the anastomosis, I said to him, and I know his opinion, what do you prefer? I do side to hand or hand to hand? He said to me, Joel, well, you know, I prefer side to hand because we always do, and we have demonstrated that it's better. And you see, we turn the column for doing side to hand. We choose anti-mesenteric side for doing the anastomosis. And as I have tried to demonstrate with the drawings, vascularization is better when we have respect completely the meso. If we do end-to-hand, a lot of people are doing completing the dissection to have the anvil not in the meso. And it is, if you choose, you have to do eventually, it is why you have seen a picture with obliquous section, you have to do the anastomosis on the anti-mesenteric side of the stapling line. So at the corner, anti-mesenteric corner, not on the middle of the anastomosis.
Right, right. So you introduced that.
It's similar as close to side to end.
Okay, and you introduce your anvil with an incision before you divide the bowel.
Yeah.
It's at least a gap of 4 centimeter from the distal margin of the staple.
Yeah.
Okay, okay. Is there any other questions coming from our residents?
But you see, it seems detail, but it is when we respect the detail that we have better results.
Mm-hmm.
I remember a friend, expert in thyroidectomy. He was doing regularly thyroidectomy and teaching. And he said to me, I don't understand. I have assisted my young pupils. He finished the procedures and the scar, and he had more complications than me. And I watched him, he was doing as me.
Okay.
And this is small details we don't see.
Okay.
In the manner of manipulation, in the technique of manipulation. So this is experience.
You at one point you told that you believe the staple to be done on the anastomotic line. That means you introduce from the anal side. It comes out right on the staple line. It's always a routine practice for you, or you doesn't matter if it comes posterior or anterior to the staple line, rectal staple line.
No, I'm close to the staple line. I'm close, but I'm on the left corner.
Okay. Do you routinely perform a air leak test in all your cases?
Yes, I do. And endoscopic control.
Does that really matter? If it's negative, does it do they not leak in some of your cases?
Leak is very exceptional now. In Asia, patients are so easy. You see, in the problem of leak, it's mainly a problem of ischemia, and particularly venous. If you have obese patient with a big meso, we have difficulty to put the colon inside the pelvis. You have edema postoperatively. You will have compression, venous compression, and you will have a risk of venous thrombosis and a risk of ischemia, late ischemia. So even if your colon is good, well vascularized, if you have beautiful ICG, if you have a fat meso, if you have a narrow pelvis, if you have a compression, the risk of postoperative ischemia and leak exists.
True. Absolutely true. Okay.
So you can be perfect and have problem.
Absolutely. Is there any other questions from our residents? Our residents have understood.
I remember a patient. I was doing laparoscopically, and I tried to pull the colon after rectal resection. It was an obese patient. He was so obese and narrow pelvis. It was a male patient. I have difficulty to pull the colon in the pelvis for doing the anastomosis. Finally, I decided to open. It was complicated too. I use my hand to push the colon inside, avoiding to break the meso. In this kind of patient, you see there is a very high risk of compression ischemia. Postoperatively, not during the procedures. And your ICG can be good.
Right. Any other questions? Yes. Any other questions from residents or faculties?
Good afternoon, sir.
Yes.
Good afternoon.
Please be visible, Balram.
Good afternoon, sir. It was a very nice presentation. I had one doubt, sir.
Using Balram's mobile. Okay.
Yes, sir. Actually, I am in OPD, sir. So from there, sir, I would like to ask, like in wherever preferable, do you prefer staplers or hand-sewn anastomosis, sir, in colorectal cases?
I think do you prefer Joel any hand-sewn anastomosis anytime? That's our resident asking. Do you prefer a hand-sewn or do you keep them for emergency scenarios, something like that? You are not audible.
Sorry.
Yeah.
For coronal, I'm only doing manual anastomosis.
Okay, that's great.
From colorectal, sometimes colorectal I will do transanal manual. But colorectal I'm doing stapling anastomosis.
Okay.
Mid or high rectum, I'm doing stapling anastomosis, mechanical anastomosis.
Okay. Yes, any other questions?
This is the advantage of mechanical anastomosis. Stapler. I'm a surgeon that known the beginning of stapler.
Right.
It was in the 70s.
Right.
And I remember in the 70s, not all the surgeons were able to do colorectal, and particularly low colorectal anastomosis manual, because we were doing open and manual anastomosis. I was doing.
It's
but
really
it was very challenging. So a lot of people a lot of patients had a definitive colostomy. They had Hartmann procedures.
True,
And
true.
with introduction of the circular stapler, this is it was considered as expensive, but finally it was not so expensive because more surgeons were able to do low colorectal anastomosis thanks to the development of circular stapler. So finally,
33 or a 31?
what?
Circular stapler, you use 33 or 31?
23? No. Circular stapler, 28 or 29, depending of company, and 31. I'm using 28
Okay, okay,
in the majority of cases.
okay,
31, it is exceptional.
right. Yes,
Because,
Siddharth, you had some other questions?
there is a risk for the sphincter when it is too big. Because the stapler, when we introduce with the anvil on, it's soft. But without the anvil, you have, it was described in the literature that the risk of internal sphincter injuries when we introduce the stapler. It's why it was proposed to introduce the stapler from up to down, not from down to up. Doing side-to-hand anastomosis from, so we introduce extremity as we do for esophagus, for the esophageal anastomosis.
No, could you repeat that again?
What?
For the side-to-end anastomosis? Yes?
Yeah, no, yes, we, the name of the technique, I have a video of that picture. We introduce the circular stapler inside the colon.
Hmm?
We introduce the anvil on the other side. We put the anvil and we put a burr string to include the anvil in the distal segment. And we staples. And we close with a linear stapler the distal segment.
Okay, okay.
I have drawings and video of that.
And that's
But
fine. That's
it is not what people are using now. So they use the technique by transanal.
yeah. I think this end-to-end anastomosis has of late has almost is getting changed to side-to-end anastomosis. It's from the vascularity ischemia point of view, it's always taken up as an ideal anastomosis, as a colorectal anastomosis. Yes, Siddhant, you have any other questions?
Thank you, sir. And I have two more questions. Do you prefer drains in putting a abdominal drain in all cases, and do you prefer covering stomas in all cases, or is there any specific situations when you use them?
Yeah.
Good question. Good question. When we are not in emergency, when regular surgical procedures, sigmoid, colon, right colon, no drain, except if it is complicated with bleeding, perioperative bleeding, and no drain.
Okay.
In rectal surgery, if it is anterior rectal, not low anterior, but anterior rectal resection, majority no drain.
Okay.
In low rectum, TME, coronal, anastomosis, always a drain, suction drain. And majority of cases, diverting stoma. Diverting for regular procedure. In emergency, diverting stoma, it will depend of experience. If you operate perforated sigmoiditis or abscess, I will do perhaps Hartmann procedure and do reversal Hartmann after. But stoma, to protect colorectal anastomosis, exceptional. It is because we operate in emergency or in a patient with high risk, as we have described, immunodepression, denutrition, and but it is exceptional to put protective stoma.
Okay. So then Siddhant, I think you are clear that drain is more required when you are going for a low rectal, I mean low anterior or ultra low anterior resections. Are not that much required in an anterior or right hemi or left hemi. You can always go out without a drain. And as regards stoma, maybe all the lower anastomosis, they need a stoma, or if the patient is on steroid, immunosuppressive, is neoadjuvant is also an indication for you, a neoadjuvant and low anterior resection. It's ideal to put a stoma, a diverting stoma.
Yes.
Yeah. So that's
I want to show you the Baker technique.
Okay. So you prefer an ileostomy for that as a
yes.
diverting stoma?
Yeah.
Okay.
I want to show. You stop your presentation. I will show you.
No, I am not. I am not presenting. I think it's your presentation is going on.
I am presenting. Where? Have you my?
Yes, yours. It's visible now with reservoir and without reservoir. Is that the one that you want to show us?
Where it is? Yes. Ok. Je pense que j'aurais pas dû faire ça. Ok. Have you some have your picture?
Yeah, it's there.
You see, it is what I was saying to you.
Okay.
Baker technique.
Mm-hmm.
We introduce in the distal segment with a reservoir or without a reservoir.
Okay.
And the anvil, and we were closing by laparotomy, putting purse string, the anvil inside the rectal stump. And we were doing the anastomosis like this, and with reservoir or without reservoir. And in this case, there was no risk for the sphincter.
Okay. Is it the routine that you always do this?
No. We stopped doing that because we do transanal. But it's only to answer using big stapler 31, and there is a risk of injury of the sphincter not far from 60%.
Okay. Because we always tend to do everything transanal. That's why I asked.
No. We do transanal. Yes.
That's true. But you do air test in all the cases.
Yes, not for coloanal because it's impossible to do for coloanal, or very low colorectal is difficult. We do endoscopic control. We control the donuts. And air test is for when we have the possibility to do insufflation. I will say mid rectum, high rectum. Yes, we do air test.
Okay. So where you divide your
air test is only to see if there is a leak. But I have tried to show there is sometimes no leak, but we have a weakness of the stapling line. And if you put your finger, you will open the stapling line. And there is no bubble when you control. I control the stump and I control before doing the anastomosis to see if there is a weakness on the stapling line, and eventually doing transfix at the level of the weakness, and doing control after the anastomosis.
You must have encountered some cases where you had no air test was negative, but still you had leak, post-op leak.
Post-operative leak? Yes,
Yeah.
probably. Don't remember. Fortunately, it's when I was younger. We have, because we don't respect perfectly the step, probably, or we did not well. Some people are using betadine. I don't like to use blue because there is a tattoo after of the anastomosis with betadine solution, with a dilution of betadine. We will see the weakness, the hole eventually, and we have no coloration of the anastomosis. So we can come back. I love air test, so I'm beginning by air test because if it is an obese patient, to have a very low anastomosis, it's not necessary to see the anastomosis.
Absolutely.
If you have bubble, you have to watch. So at this moment, I will use betadine, betadine solution, dilution of betadine solution. And I will verify from where it's coming, posterior, anterior, to see. And I have shown some leak, huge. It was a defect, an error of purse string. Because when we do a purse string with a device, specific device, we have no purse string at the two extremities. And sometimes you have the mucosa that is not included in the purse string.
Okay. But
I have shown one case.
Okay. But Joel, if we found a complete do not, still are you skeptical that there is anastomotic descent somewhere after your firing?
I will say normally yes, but we know that if there is a small ischemia at this level, you will have a risk of leak. It's why respecting a good vascularization of the rectal stump, doing side-to-hand anastomosis, in my opinion, it's safer because we keep the vascularization. And when we do side-to-hand anastomosis, we have the possibility doing side-to-hand in the low rectal resection. It's because we have mobilized enough the column.
True. And quite often that if when we are getting a complete do not, so we know that the anastomosis is surely a complete all around. Do you agree with me or not?
I was not well understood. Repeat.
I think when we have fired the circular step,
there is some echo. There is some echo. I don't know why. Perhaps it's me.
I think all okay. Is it better now? Is it better now?
It's same.
It's same. But we are all. I don't find any echo from your side. You are absolutely clear to me.
Yeah, but you have echo, but it's okay.
Okay.
But if you speak slowly, it would be better because your voice is repeated.
Okay. Let me make my volume low. It's better now? Is it better?
I don't. No. It's okay. I understand, but you have to repeat.
Yeah, okay. I mean, I was just telling that when you have fired the circular stapler, you have found the donut is complete. So quite often you are sure that there is should not be any gap in your staple line. That's what I just wanted to tell you. And we are doing a side-to-end anastomosis. You are protecting the vascularity, so it should be filling. I mean, that's about the air test, the air leak test that I was just focusing. That you, as a routine for every case, doing it, is it justifiable, or you have, just from your experience you think that yes, or it is you are fixed with an idea that probably it's helping me more, something like that?
No, it's not because verifying the donuts, it is sure that we have to do systematically.
Okay.
Concerning the hair test, for American, it's necessary to always do endoscopic control for two reasons.
Okay.
Verifying a perfect closure of the stapler and to see if there is weakness.
Okay.
Verifying that there is no bleeding, because often, not often, but sometimes there is bleeding, and we have to control immediately, because you can have postoperatively, rapidly, big bleeding, and the patient is awake. It's not a good moment to come back to the operating room. To do the endoscopic control, putting a clip, not really a big operation, but it's not what we wish. And they do systematically endoscopic control. I always do digital anal examination of the anastomosis to verify if there is some dehiscence. But it is also to verify there is no stenosis. And air test, as I said, it's not for the very low rectal anastomosis because we cannot. So it is mainly the digital examination that we will do. And the air test, as I said, some people are not doing, or they do betadine test or test with blue to verify if there is leak. But this is not to prevent a leak, it's to find if there is one. But it's not a test to be sure we will not have a fistula postoperatively.
Absolutely, absolutely. Is there any further question?
I do that since always, and I continue teaching, because you see, even this, it's a technique to teach. And when I have young colleagues, surgeons, they wish to know how to do.
Right, right. I got it, got it. Is there any further questions from anybody? Any residents, faculties, anybody?
But in America, when they do endoscopic control, they insufflate. So they insufflate and they do finally air test without thinking they are doing.
Okay, they put in the colonoscope and insufflate for every case after the staple line is fired, the staple is fired?
I don't do systematically endoscopic control.
Okay.
Sometimes I do.
Okay, fine. So thank you, Professor Joel. That was a wonderful discussion for last 2 hours. I think it's pretty clear for our residents and faculties. Everybody is happy to have you amongst us. It was a wonderful afternoon in India and a wonderful morning for you. Might be you might not have taken your breakfast till now.
I have had my breakfast.
Okay. You must have had some cake from yesterday.
I will drink another coffee.
You must have kept some cake for me also from yesterday night.
Yeah, yes.
Your birthday. Okay, that's great.
Yeah.
That's great. It was
a good cake in India. Very sweet.
Great. Great.
Too sweet.
So as you grow older, I think your value is rising like anything. It's like a French wine. As you grow old, the taste and value goes up.
Thank you. It was
Thank
nice.
you. Thank you very
Hope,
much.
will be useful for the beginner. It's useful for discussion, and it's good.
So I think it was an excellent session for our residents, and more than the teaching, your presentation, having you amongst us, you are always an inspiration. You are a motivation for everybody. So thank you very much. Thanks a lot, and thanks for joining us. Thank you.
Thank you.
Yeah, maybe some other time we'll
Thank
surely have you.
everybody for their participation.
Thank you, sir.
Thank you. Thank you. So thank you everybody for joining. So we'll be signing it off.
Thank you.
Thank you. Thank you.
Bye.
Bye-bye. Bye-bye.